Welcome to Pediatric Case Review. Today's lecture covers Treacher Collins Syndrome, a rare craniofacial disorder requiring specialized multidisciplinary care. We'll explore genetics, clinical presentation, diagnostic approaches, and comprehensive management strategies. This presentation aims to enhance your clinical recognition and treatment planning for affected patients. Let's begin our detailed review. Question 1 presents a 25-year-old woman with Treacher Collins Syndrome seeking genetic counseling before pregnancy. What is the inheritance pattern of Treacher Collins Syndrome? Option A, X-linked recessive. Option B, autosomal recessive. Option C, autosomal dominant. Option D, mitochondrial inheritance. Consider the genetic transmission pattern. The correct answer is C, autosomal dominant. Treacher Collins Syndrome primarily results from TCOF1 gene mutations on chromosome 5, showing autosomal dominant inheritance with nearly complete penetrance. However, 60% are de novo mutations. Affected parents have a 50% recurrence risk per pregnancy, making genetic counseling essential for family planning. Question 2. Which gene is mutated in approximately 80% of Treacher Collins Syndrome cases? Option A, PULR1C gene. Option B, PULR1D gene. Option C, TCOF1 gene. Option D, FTUD2 gene. Think about the most common genetic mutation associated with this craniofacial syndrome. The correct answer is C, TCOF1 gene mutations account for approximately 80% of cases. This gene encodes treacle protein, crucial for ribosomal RNA transcription. While PULR1C, PULR1D, and FTUD2 cause similar phenotypes, they're much rarer. All mutations disrupt ribosome biogenesis, particularly affecting neural crest cell development during embryogenesis. Question 3. What is the primary pathophysiological mechanism in Treacher Collins Syndrome? Option A, excessive neural crest cell proliferation. Option B, deficient neural crest cell migration and apoptosis. Option C, abnormal endodermal differentiation. Option D, mesodermal tissue overgrowth. Consider embryonic development processes. The correct answer is B. Impaired ribosome biogenesis causes increased neural crest cell apoptosis during embryonic development, specifically affecting first and second branchial arch derivatives. This occurs during weeks 5 through 8 of gestation, resulting in characteristic mandibular, zygomatic, and ear hypoplasia. This explains the symmetrical bilateral craniofacial abnormalities. Question 4. A newborn presents with downslanting palpebral fissures and micronathia. Which facial feature is considered pathognomonic for Treacher Collins Syndrome? Option A, cleft lip. Option B, bilateral malar hypoplasia with downslanting palpebral fissures. Option C, hypertelorism. Option D, macroglossia. Identify the characteristic diagnostic feature. The correct answer is B. Bilateral malar hypoplasia with downslanting palpebral fissures represents the pathognomonic feature. Zygomatic bone underdevelopment creates characteristic facial appearance. 75% have lower eyelid colobomas with absent medial eyelashes. This antimongoloid slant differentiates Treacher Collins from other craniofacial syndromes. Severity varies considerably between individuals. Question 5. An infant with Treacher Collins shows bilateral ear malformations. What percentage of patients have ear abnormalities? Option A, 25%. Option B, 50%. Option C, 77%. Option D, nearly 100%. Consider how commonly auricular defects occur in this syndrome. The correct answer is D. Nearly 100% of patients have ear abnormalities. These range from mild microtia to complete onotia. Middle ear ossicle malformations cause conductive hearing loss in 90%. External auditory canal atresia is common. Importantly, inner ear structures typically remain normal, making bone conduction hearing aids effective. Question 6. What mandibular abnormality is characteristic of Treacher Collins Syndrome? Option A, prognathism or protruding jaw. Option B, micronathia with steep mandibular angle. Option C, asymmetric jaw development. Option D, normal mandible with isolated dental issues. Think about the jaw characteristics in this condition. The correct answer is B. Severe bilateral micronathia with steep mandibular angle characterizes Treacher Collins. The gonial angle typically exceeds 130 degrees. This creates significant airway compromise, especially in neonates, and causes feeding difficulties. Mandibular hypoplasia severity directly correlates with respiratory complications, often requiring immediate airway management. Question 7 presents a newborn diagnosed with Treacher Collins developing respiratory distress immediately after birth. What is the immediate priority in neonatal management? Option A, genetic testing confirmation. Option B, hearing assessment. Option C, airway evaluation and securing. Option D, feeding tube placement. Consider life-threatening priorities. The correct answer is C. Airway management is the immediate priority. Severe micronathia and glossoptosis create upper airway obstruction. Prone positioning may provide temporary relief. Anticipate difficult intubation due to facial anatomy. 15% of severe cases require tracheostomy. Anesthesia and intensive care teams should be immediately available for airway management. Question 8. What percentage of Treacher Collins patients have cleft palate? Option A, less than 10%. Option B, approximately 30%. Option C, 50 to 60%. Option D, over 80%. Consider the frequency of palatal defects in this craniofacial syndrome. The correct answer is B, approximately 30% have cleft palate. Unlike typical cleft lip associations, Treacher Collins primarily affects the palate. This ranges from minor bifid uvula to complete palatal clefts, significantly impacting feeding and speech development. Surgical repair is typically performed between 9 and 12 months, followed by speech therapy. Question 9. A 3-month-old with suspected Treacher Collins needs imaging to confirm craniofacial abnormalities. Which imaging modality best demonstrates bony facial abnormalities? Option A, skull X-ray series. Option B, magnetic resonance imaging brain. Option C, computed tomography craniofacial bones. Option D, ultrasound facial structures. Select optimal imaging. The correct answer is C. Computed tomography with three-dimensional reconstruction provides optimal visualization of craniofacial bony abnormalities, including zygomatic hypoplasia, mandibular defects, and middle ear ossicle malformations. This imaging is essential for surgical planning. Temporal bone CT specifically evaluates ear canal patency and ossicle anatomy for hearing rehabilitation planning. Question 10. A 6-month-old with Treacher Collins fails newborn hearing screening bilaterally. What type of hearing loss is most common? Option A, sensorineural hearing loss. Option B, conductive hearing loss. Option C, mixed hearing loss. Option D, central auditory processing disorder. Identify the predominant hearing loss pattern. The correct answer is B. Conductive hearing loss occurs in 90% due to external canal atresia and middle ear ossicle malformations. Loss ranges from 30 to 60 decibels bilaterally. Crucially, inner ear function remains normal, making bone-anchored hearing aids highly effective. Early amplification before 6 months is essential for normal speech and language development. Question 11. Which findings establish clinical diagnosis of Treacher Collins syndrome? Option A, genetic testing alone. Option B, bilateral symmetrical craniofacial features with malar hypoplasia. Option C, isolated hearing loss. Option D, single facial feature abnormality. Consider diagnostic criteria for this syndrome. The correct answer is B. Diagnosis is primarily clinical, requiring bilateral symmetrical craniofacial features, specifically malar hypoplasia with characteristic facial appearance. Major criteria include zygomatic hypoplasia, downslanting palpebral fissures, and ear malformations. While genetic testing confirms diagnosis, characteristic clinical features alone suffice. Symmetrical bilateral involvement distinguishes Treacher Collins from hemifacial microsomia. The correct answer is B. Comprehensive care requires extensive multidisciplinary collaboration. Essential team members include craniofacial surgeons, ENT specialists, audiologists, speech-language pathologists, geneticists, and feeding specialists. Psychosocial support is equally important. Regular coordinated team evaluations ensure optimal outcomes. This lifelong approach addresses medical, surgical, developmental, and psychosocial needs throughout growth and development. Question 13. A 6-month-old with severe micronathia and persistent airway obstruction despite positioning. When is mandibular distraction osteogenesis typically considered? Option A, at birth immediately. Option B, infancy if severe airway compromise. Option C, after 10 years of age. Option D, only in adulthood. Consider intervention timing. The correct answer is B. Mandibular distraction osteogenesis is performed in infancy for severe airway obstruction unresponsive to conservative measures. This technique gradually lengthens the mandible, improving airway patency and potentially avoiding tracheostomy. Performed as early as 6 weeks, distraction occurs over 2 to 3 weeks, with high success rates for respiratory improvement. Question 14. At what age is zygomatic and orbital reconstruction typically performed? Option A, infancy under 1 year. Option B, preschool age 3 to 5 years. Option C, school age 5 to 7 years. Option D, adolescence after growth completion. Consider optimal timing for facial reconstruction surgery. The correct answer is C. Zygomatic and orbital reconstruction is typically performed between ages 5 and 7 years. This timing allows sufficient facial growth for stable reconstruction while addressing appearance before intensive peer socialization. Bone grafts, often autologous rib, augment malar regions. Secondary revisions may be needed during adolescence after growth completion. Question 15. A newborn with Treacher Collins has severe feeding difficulties and poor weight gain. What initial feeding intervention is most appropriate? Option A. Continue oral feeding attempts only. Option B. Immediate gastrostomy tube placement. Option C. Specialized bottles with modified nipples and positioning. Option D. Total parenteral nutrition. Select appropriate initial management. The correct answer is C. Initial management includes specialized feeding equipment with modified nipples and careful positioning. Haberman or pigeon bottles allow better milk flow control. Upright positioning reduces aspiration risk. If these measures fail to achieve adequate growth, nasogastric tube supplementation is considered. Gastrostomy tube placement is reserved for severe, persistent feeding difficulties. Question 16. A 4-year-old with Treacher Collins has significant speech delays. Which factors contribute to speech difficulties in Treacher Collins? Option A. Cognitive impairment primarily. Option B. Hearing loss, cleft palate, and structural abnormalities. Option C. Only hearing loss. Option D. Lack of speech therapy access. Identify contributing factors. The correct answer is B. Speech difficulties result from multiple factors. Conductive hearing loss impairs auditory feedback, cleft palate causes velopharyngeal insufficiency, and mandibular hypoplasia affects articulation. Importantly, intelligence is typically normal. Comprehensive management includes early hearing amplification, surgical cleft repair, and intensive speech therapy. With proper intervention, speech outcomes are generally favorable. Question 17. What percentage of patients experience vision-threatening complications? Option A, 5%. Option B, 10 to 15%. Option C, 35%. Option D, 60%. Consider the frequency of serious ophthalmologic complications in Treacher Collins syndrome. The correct answer is A. Approximately 5% experience vision-threatening complications. While lower eyelid colobomas and ectropion are common, serious vision loss is uncommon. However, refractive errors, strabismus, and exposure keratopathy require monitoring. Regular ophthalmologic examinations are essential. Protective eye lubrication and corrective surgery, when indicated, preserve vision. Most patients maintain good visual function. Question 18. A 10-year-old with Treacher Collins reports bullying at school and social isolation. What psychosocial intervention is most important? Option A, homeschooling to avoid peer interaction. Option B, comprehensive psychological support and peer education. Option C, delaying all social activities. Option D, medication only. Consider appropriate psychosocial management. The correct answer is B, comprehensive psychological support is crucial. Despite normal intelligence, children face significant social challenges from facial differences. Interventions include individual counseling, family therapy, school-based peer education, and connection with support groups. Anti-bullying programs are essential. With appropriate support, most individuals achieve excellent psychosocial adaptation and quality of life. Question 19. Parents with one affected child inquire about recurrence risk for future pregnancies. If neither parent has Treacher Collins, what is recurrence risk? Option A, 0% with no recurrence. Option B, 1 to 2% low recurrence. Option C, 25%. Option D, 50%. Calculate appropriate recurrence risk. The correct answer is B. When neither parent is affected and the child has a de novo mutation, recurrence risk is 1 to 2% due to possible gonadal mosaicism. If a parent is affected, recurrence is 50%. Prenatal testing through amniocentesis or chorionic villus sampling can detect known mutations. Preimplantation genetic diagnosis is available for identified familial mutations. Question 20. What is the life expectancy for individuals with Treacher Collins syndrome? Option A, significantly reduced under 40 years. Option B, mildly reduced 50 to 60 years. Option C, normal life expectancy with appropriate care. Option D, cannot be determined. Consider overall prognosis with modern management. The correct answer is C. With appropriate multidisciplinary management, individuals with Treacher Collins syndrome have normal life expectancy. Early airway management is crucial for survival. Normal intelligence allows full educational and vocational achievement. Multiple surgeries improve both function and appearance. Most individuals achieve independent living, successful careers, relationships, and can have children. Overall prognosis is excellent. We've completed our comprehensive review of Treacher Collins Syndrome, covering genetics, clinical presentation, management, and outcomes. Remember, early airway management and multidisciplinary care are essential. Thank you for watching Pediatric Case Review. Please subscribe for more informative medical presentations. Share your questions or case experiences in the comments. See you next time.